Jens, thank you very much for this warm welcome. Ladies and gentlemen, colleagues, I'm very happy to be here. I feel really honored to actually have received this honorable lectureship. I met John Jane, as you have heard from Jens already, in Bochum. I, as a trauma surgeon, actually at that time was never in contact with neurosurgery in that sense, and so I didn't know him. But I got to learn about him, and I learned of him as a very sincere, very encouraging person who actually in these discussions which we have in Germany about this new technology was very helpful for our minds, and he encouraged us to go ahead with this, in our eyes, great research. Therefore, I'm very happy to present this work to you, and I hope that we will have plenty time of discussion. As disclosure, all of this work goes back to 5, almost 6 years, and was funded by the German government, of our state, by the European Union, by the Japanese government, and by the BG, which is similar to your LNI, and most recently I became a consultant for that company. Well, as an overview, I want to show you a few pictures again of our place, and then I want to talk to you about what is actually an exoskeleton, what is, in our understanding, the current perspective in SCI rehabilitation, and then, of course, I want to show to you and share with you our results with the HAL robot suit. Well, this is Germany, and our hospital is part of a trauma hospital network in Germany. All the LNI hospitals are now connected in a one large company, and they take care of all the trauma cases which are related to work, on the way to work, or on the way back home. All complications, secondary trauma, are treated there. And in that sense, as mentioned already, this was built through the social, or after the social laws from Bismarck came up in the 19th century as a trauma center, which was at that time a pretty new idea. And you can see here the pictures of our institution at the beginning. And you see that the radiology department came up already in 1896. You may remember that X-ray was founded in 1895. So new developments always were put into such trauma system in Germany. And you see our physical therapy in 1892. So the idea to have a professional physical therapy connected to the hospital surgical treatment was already a routine thing at that time. Well, what is an exoskeleton? An exoskeleton is a machine which somebody wears, which should increase the endurance and strength of the wearer. It should increase motion magnitude and dimension, and typically it's used not, or it was developed initially not for medical use, but for industry and certainly for military. And there are different systems out there in the medical field nowadays, and I just want to briefly talk to you about two. One is the exobionic system, which allows the wearer to actually walk with that system. However, this is a passive system. The system is initiated by pressing a start button or by certain movements the patient is doing, and then the machine starts, and actually the person can walk, get up from a chair, or actually climb stairs. And the same system roughly works with ergomedical rewalk system. So this is also a passive exoskeletal system, which is controlled by a wrist board, control board, where you can start several programs for standing up, sitting down, and walking. However, as I said, these are passive systems where the patient is actually moved. He is not in direct active neural control. And that is the difference towards the system which we are using, which was built by Professor Sankai and founded by him and developed by him in Japan. And he out of his institute, made an offspring of a company which is called Cyberdyne. He developed several robotic systems for industry, for arms, for legs, whole body versions, etc. And the thing how it works is, if we want to perform a motion, then we start with a signal in the brain. The signal goes to the spinal cord, and then, for example, in a spinal cord injured patient who has an incomplete injury, a weak signal continues towards the peripheral nerve and the muscle. And then, depending on this dimension of the signal, the muscle is able to contract in a meaningful way, and the person can move, or he or she cannot. However, this signal is taken up by a sensor from the machine and put into a motor of that robot, and by that the muscle is supported by the motion of the robot. That way, the patient or the person is in direct control of each motion the machine is doing. So if there is no voluntary signal coming towards the muscle, then the machine is not moving. And therefore, you have now a closed feedback system. And that helps in our way of thinking for a neuromuscular feedback, which we need to build up again in these patients a muscle. So to result in muscle hypertrophy, we need such a feedback system for nervous system regeneration and reorganization. And therefore, we think that this system is quite different from all the other exoskeletal systems which are there on the market for our patients. Well, medical indications, there are lots of indications which can be thought of. We don't know really whether the system is working in all of these diagnoses. But since we are a trauma center and have a SCI specialty unit, we decided 5 years ago that we really want to look into the treatment of SCI patients with that system. To give you a couple of numbers, we have around 2,000 new spinal cord injury patients per year, and we know these numbers because all the data are collected in a German database, the EMSCI database, and there we have actually follow these patients, and we also have numbers on the consecutive secondary admissions of these patients, and you see that the secondary problems in these patients are the mainstay which have to be actually treated. What can be nowadays roughly expected in the neuro-rehabilitation of these patients? Well, we know that the lower extremity motor score is being able to increase during the first year. Neurologic improvement can occur during that year, but mainly depending on the injury and type of lesion between 6 and 9 months. But after 1 year, typically there is no or only minimal and typically non-functional improvement. And we know that from the EMSCI database, from the German database, where you see here, just for example, some of the Asia motor scores and the SCIM data for different injuries. But you see on the x-axis the days, so 1 year, and you see all these functional results are more or less leveling out after 1 year. Also, complete SCI injured patients rarely can walk, depending on remnant function zones of partial preservation, and age also has a significant influence on the prognosis of the rehab. What are the mechanisms which are standing behind a possible improvement of the neurological function and the functional outcome of these patients? Well, first of all, neuroplasticity plays there a role. There are adaptive reorganizations and new interconnections in the brain and in the spinal cord, which we know through animal studies. We also know that the cortical extremity representations and the spinal cord interconnections are changing with the injury, but also through the treatments, whatever we do in the rehab. We know that there is axonal sprouting above the lesion in the spine, and we also know that in the periphery, intramuscular nerve sprouting and muscle fiber hypertrophy plays an important role in the neurorehabilitation. Well, on a more practical standpoint, mobilization and walking in these patients is very cumbersome. Standard of care is to mobilize these patients in a body weight support system on a treadmill with manual support. Sometimes there are trials with electric stimulation, combinations of these things, and we know that there is a significant increase in walking speed if we do this rehabilitation, but it seems that there is no significant difference in the different ways of neurorehabilitation at all. So it matters that we do something, but what we do does not make a big difference. And that was the reason why various automatic and robotic assisted aids are in the discussion and in trials since decades. There are three things which they should work for. They should simplify our initial training. We hope that it improves early functional results in our patients. And of course, for the future, we always hope that it optimizes and simplifies walking and mobilization in the chronic phase of patients. But that meant that these systems should initially work as an high-tech auxiliary tool in these patients and not for treatment in chronic injured patients. And one of the first systems which are more or less accepted in Germany and in most centers are automated locomotor training systems, the Locomat training, which is actually a bodyweight support system and a system where the patients are connected to a robotic device, and then they are passively moved on the treadmill. We know that this makes a difference as for walking, and it improves overgrown walking. But again, this system does not make significant changes overall if the patients are outside of that systems. So the requirements for walking aids and orthosis seems to be still the same with and without that training. If we talk about rehabilitation, we have to differentiate between neurologic outcome and functional outcome. There is quite a difference. We know that the functional outcome is increasing in these patients much better than often the neurologic outcome. But also on a more realistic standpoint, complete or high-grade incomplete SCI patients are typically rehabilitated to a wheelchair status, and that's it. And then we are happy and we close the rehabilitation and we say and state this is successfully completed. And after 1 year, we do not expect any functional changes anymore. However, in the last years, there are different new approaches as I have listed, and these are often not really in our minds. And I think and I propose that we really have to change our thinking in the neurorehabilitation. We have to stop being happy to have the patient well mobilized in a wheelchair. We have to think, what can we do and add so that the patients get back out of the wheelchair and walk again. And with that, I want to start and show you our experience with the HAL system. This is the HAL robot as you see here, which has 2 legs. It has the machines here, the motors. It has different connected systems for the sensors, which are on the legs. It has control units here in the back, with which we can actually visualize all the EMGs from the sides of the muscle groups for the lower extremity, and quite nice adjustable systems here for different people. So it's very easy to apply to the patient and to set actually up in different patients. And on these pictures, you see the sensors for knee extensions and flexion, and as well as the sensors then for hip flexion and extension. You see one of our first patients in a body weight support system on a treadmill. The robot is applied, the control unit used here, and then the training actually starts. And this is one of our first patients, and some of you might have seen some of the videos here. He went through the LNI rehab training for 1 year, which includes really the maximum amount of rehab which is possible. So he was on a constant basis, and you can you realize that this person with this Asia A injury below T12 with zones of partial preservation up to L3, but he is wheelchair bound functionally. He needs personal assistance. He needs a walker, and that was it. And he came to us with this status, and he started in the lower film on the left, on the right corner here with the machine. And you see that all the steps are very cumbersome. He has to think about every step that he actually has to do. What we see in these patients, they are learning again to walk. They think about every step, but when they continue doing that, it becomes much easier for them from training to training. And we started to train them for right from the beginning 5 times per week. And did that for actually 3 months, and we recorded walking speed, walking distance on the board, on the treadmill with the robot, but we also wanted to find out whether the actual functional result outside of the robot is getting better. And therefore, we also looked into functional parameters like the 10-meter walk test without the health system. And what we saw in that patient, he started for a 10-meter walk distance with 31 steps and actually 72 seconds. And what we observed, that this decreased significantly after a couple of months, up to times which were quite incredible and which were not expected at all at that time. So it seemed to us that this is not just a high-tech tool which patients can use to walk again, but it's a training tool. But these are just numbers. However, the videos, I think, are presenting much nicer the change of the status of this patient who already was on a constant and finished rehab status. You see him at 3 months, and you see him at 5 months on this roller here, on this walker, just by himself. And with that, we were able to actually get this patient outside, out of the wheelchair, up to walking, of course impaired walking, but walking abilities, but he is now independent. And this was something which was really striking to us and not expected. Jens, do you have a pointer?
Sorry, no.
And this is, maybe Jason can give me one. This is how you see, where you see the difference when he walks on the treadmill. And it looks very easy to him and almost automated at the end. We continued in this patient with the training, and he actually went further on, actually on crutches. And he is now actually able to walk stairs 1 level. But that was the status.
Doesn't really work. So
Okay. But that was the status in this patient, and that is all, we would say, what we could get out of him. He hoped, of course, more, but we were pretty amazed about these results. Well, these functional results we saw in every patient, and you have to remember that we at the beginning included only LNI patients, full-term, at least a minimum of 1 year rehab, standard rehab training, and all chronic patients. But I want to show you now a few more things which we have seen in these patients. So this is another lady, Asia C. She went through the same training, and then after 3 months, she continued in an interval training about 1 time per week. And she, after 9 months, came up and said, I do not need self-catheterization anymore, which was also very striking to us. And we have a couple of patients who describe the same thing, and we do not know what is really happening there. It may be because there is some effect on the autonomous nerve system. There may be just a regular strengthening of the musculature in the pelvic area, which comes up with general training of these patients. But at least that is something which we observe in some of the patients. This is a gentleman who had his injury already in 1996. About 6 months before this video was taken, he fell out of a wheelchair and broke his femoral neck. He had a paired trochanteric fracture, and he was treated, which threw him, of course, also back in his functional abilities. However, he started the training, and he amazingly and quickly regained functional function again. And with that, he actually is able to walk and take care of himself in his normal daily life. However, he developed some other very interesting result. This was his sensory status when he started. And all of our patients, when they train, they describe like a vital sensation in the legs, and we always describe that as maybe because of the blood circulation is changing. We all know that we have a different feeling in the legs when we go and do heavy sport activities. However, there was an objectable change in his pin, prick, and light touch status in not the adjacent to the injury level section, but to S2. And again, also on the other side after about 9 months. And we saw also that in quite a lot of patients, some changes in the neurostatus, minimal changes, sometimes with skip segments, most of the time with adjacent levels, at adjacent levels. Another point, we know that in spinal cord injury that there is a somatotope reorganization in the M1, S1 areas, and we know that there is a medialization and enlargement of the representation of the hand. This reorganization correlates with neuropathic pain, and in our studies, we started with functional MRI in our patients right from the beginning. We couldn't do that in all the patients because tattoos, hardware, etc. were a problem. However, we have a series of patients, and we could show that there was quite a big change in the activity of the hand regions. We looked at the representation of the hand regions because that was easier. This showed us, however, that there was a difference in the reorganization happening in the cortical areas of the leg as well. We could show that there was that the training changed the cortical excitability and the somatosensory cortex. Well, if that is true, and if we know that this has influence on the neuropathic pain, then it should change at least the pain level in some of our patients. And indeed, this happened also in a few patients, not every patient with neuropathic pain. This was the first of these patients, and he described a reducing a shooting pain in his legs with the training. And this actually continued that we could take off completely his opioids in the consecutive training, and I will address that in a second again. Well, we started with a pilot study. These were our first 8 patients, and you see the length since trauma. 13 years, this is in years, so at least 1 year. And in all of these patients, we had highly significant changes in the functional data on the treadmill with the robot, okay, but also in the 10-meter walk test and the lower extremity motor score in only 8 patients. Also, the 6-minute walking test in these patients, only at the beginning, only 3 of the patients could do that. At the end, all of them could do that, made a significant change. So the first impressions from the pilot study were very encouraging, and therefore we were able to build up a complete new training center, which you can see here, where some of you have been. And I show you here the most recent data. We have now treated more than 100 patients, and these are the results of 50 chronic SCI patients, chronic meaning out of injury for more than 1 year. And you see that the significance increased by by several factors compared to the pilot study. These were the data on the treadmill. You see the walking distance on the treadmill, the walking speed, and the walking time. And these are the 10-meter walk test, the steps needed for the 10-meter walk test, 6-minute walk test, and time up and go test. So the patient gets up the chair, which is difficult, goes a distance, sits down again. And also, as I mentioned before, the LEMS seems to change in some of the patients. It seems to be in this number here of 34 patients significant. The next question would be, are these results consistent? And we looked into, we invited again our first 8 patients from the pilot study. These patients were treated for 3 months. Like all patients, like 5 times a day. And after that, 8 out of the 8 patients, 4 trained 3 to 5 times continuously for 1 year, and the other 4 trained about once a week. And we looked into the different data. Of course, I know this is a very small number. However, the results, overall results of all 8 patients was similar. The walking distance was the same on the treadmill, but it was similar in all functional results. So it seems to us that as soon as the patients are on a more active level, where they can actually walk during daily activities, that they keep themselves on a training level every day without actually having to go through a high intense rehabilitation training further on. The neuropathic pain I want to address again. It is prevalent in SCI, and quite depending on the literature, in a quite number, we have treatment refractory pain. These were the pain scales of 2 of our patients from the beginning, and you see the medication in these patients. Since we know the effects of some of the medications on the liver enzymes, we looked and checked the liver enzymes because we wanted an independent control whether it's true that they are not taking the medication, and indeed these liver results became better. If we have such encouraging results in chronic spinal cord injury patients, then of course it was obvious to us that we should go in early on neurorehabilitation in acute patients. Of course, we know that there is quite a number of patients who become better anyway. So there is no good control. However, we started with that, and what was striking to us is the speed with that these patients actually became better. So, acute spinal cord injuries. What is interesting here, or important for us to know about the conversion rates, and there are quite big differences in the literature what the conversion rates are. The interesting patients for us in acute spinal cord injury are the Bs and the Cs, and we want to know how these patients change with neurorehabilitation. I just want to show you the first 3 patients which we had, and we actually were struck by the speed with that these patients become better. This was a 35-year-old gentleman, incomplete paraplegic, below T10. He started the training 8 weeks post-injury, and you see him here 8 weeks after start of the training. And then the picture on the treadmill, and here you see him after 4.5 months, and you see him on the treadmill actually climbing up, going up. And then he was lost to follow-up. He was an LNI patient, and if they have impairment, they get a certain amount of money, and he did not come back to any re-evaluation. And that is the reason why. He lost some of his pension when he came back after 1.5 years with that function. So that was the reason, but it was striking to us. However, this was an acute injury. This is a lady with a spinal cava nova, 3 weeks post-injury, and she started the training as well. 4 weeks after training, 3 months after training, climbing upstairs. And Sorry, the others I will show you later. These are the results of the initial 25 patients in a consecutive series. So no a selected patient group. These were a consecutive series. And there again, we see highly significant differences in the parameters with the robot suit on, but also with the functional results here, 10-meter walk test, the steps needed, a 6-minute walk test, and time up and go test. Also LMS changed, but however, these are incomplete patients in the acute situation. So we see the indications for the HAL training in incomplete paralysis below C5-6. Muscle strength should be Yanda, according to Yanda 1 to 2. Sensomotoric complete conus cauda lesions with zones of partial preservation with some function in the hip and knee should be there, and then patients can be treated. However, there are contraindications as well, just limitations with the suit. Other things like contractures and decubital ulcers are clear. And the aim of using that system is functional improvements of these patients without wearing the robot suit. So we are not using the exoskeleton as a tool to mobilize the patients. This might be possible with that system, but this is not what we do. We use the HAL system not for regular treadmill training. We use it in a variable applications. You see that in such patients, they balance their walk by also visual control, by looking at the floor. We want to get them independent. So we do things on the treadmill with like distraction training. They have to catch the ball and walk. They go backwards, uphill, downhill, all these things. They can walk over obstacles. So we try to get them actually into an active training mode for their real life. We also use the system in independent walking training, for balance training with some support, without support, and so on. So the main thing is to get these patients independent. This is a patient, LNI, 7 years post-trauma, and that is what he can do. So he is wheelchair bound. You see the data on him there. He needs a person to actually be able to walk there. And you see him here, independent, getting up the wheelchair, and then walk with a walker after 3 months of training, which is pretty stunning to us. In acute patients, this is one of our most recent patients here from the United States. She is an artist and fell off a trampoline. She is now just 6 weeks in a training. She had a C3-4 dislocation in October. She was on ventilation till February. She started training in April, and she is now 6 weeks out. And she will go back to the States in a couple of months, and we hope, of course, that there may be a chance for her to be treated in follow-up here, maybe in Seattle. You see her there, not really using the crutches after 6 weeks of training. Well, let me talk the end again. I think this is the last example, a plane crash, but this is similar. What is the mechanism behind it? Well, the voluntary drive in the training, plus the normalized motion system, which is possible with this HAL robot suit, we think helps us for muscular hypertrophy in the following, even after a year. There may be peripheral neural sprouting. We assume that from our animal studies, but we do not know in our patients. But it definitely is a foundation for proprioceptive feedback loop. And this neural activity and the repeated executions of the walking helps to promote learning, leads to reinstatement and restructuring of the proprioceptive feedback. And the locomotor training restores, that is what we know from the literature, the spinal reflex circuits and promotes the presynaptic inhibition. And that, again, helps us to also coordinate the different muscle groups in the lower extremities and especially in the impaired legs. With that, with our studies, we also could show that the renewed S1 and M1 representations, the cortical representations, are there for the legs, and this is likely related to recruitment and more effective use of the remaining pathways and cortical spinal tracts in the spine. And we don't know about that, but we hope that with these data, we encourage much more research. There is much too less research out there at this time point. We see lots of changes in the functional results of our patients, which we still to large extent do not really understand, and we need other research groups to actually look into that. And with that, I want to close, and I want to thank again the Seattle Science Foundation for having me here. I sincerely want to thank again Dr. John Jane, who encouraged us to continue that and was with that in the background a big proponent for this research and this activity. And I want to thank, of course, Jens and Rod for actually following up with that studies and helping us to actually build it up here in Seattle, hopefully very soon. Thank you very much.
Thank you.